Hi, everyone. Thank you for joining us for the Remember the Girls 7th webinar of our 2021 webinar series. Remember the Girls is a nonprofit organization dedicated to supporting and advocating for carriers and female patients of X-linked disorders, a group often overlooked by the medical profession. I'm Taylor Kane, the founder and executive director of Remember the Girls and the moderator for today's event. The topic of this webinar is newborn screening advocacy and the implications of identifying X-linked carriers. We'd like to thank the sponsors of our 2021 webinar series, Horizon Therapeutics, Bluebird Bio, Ultragenyx Pharmaceutical, and Sanofi Genzyme. Today, we are joined by Abby Watts-Dickens. Abby is a board-certified genetic counselor in the newborn screening program in the Division of Clinical and Metabolic Genetics at SickKids Hospital in Toronto, Canada. Abby obtained an honors Bachelor's of Science in Genetics from the University of West Ontario and obtained a Master of Science in Genetic Counseling at the University of British Columbia. After completing her training, she joined the Department of Medical Genetics at BC Women's and Children's Hospital in Vancouver, Canada. She was certified by the American Board of Genetic Counseling in 2017 and joined SickKids Hospital Newborn Screening Program in 2018. At SickKids, Abby's patient population are infants and their families who screen positive on the province of Ontario's newborn screen, which currently screens for over 30 conditions. Abby is involved in the clinical supervision of genetic counseling students and medical trainees at the University of Toronto and is a lecturer in the Department of Molecular Genetics at the University of Toronto and has served as a committee chair with the Canadian Association of Genetic Counselors. Abby is going to be giving us an overview of newborn screening and discussing the implications of X-linked carriers being identified through this public health program. She will also be taking questions, so be sure to send any questions that you have in the chat or the Q&A function. But first, we have a video to share from Marianna Raia, the Associate Director of Expecting Health, about the organization's newborn screening advocacy program. So I'm going to share my screen and show Marianna's video.
Hi, my name is Marianna Raia, and I'm the Associate Director of Programs at Expecting Health. I want to thank you so much for the opportunity to join you today and share with you a little bit more about the work that we're doing at the Newborn Screening Family Education Program. We have a number of tools and resources available to you, and I'm eager to share with you today specific ways that you can learn more about the newborn screening system, develop your own advocacy skills, and really get involved with the work that we're doing. I want to thank Taylor and Emma and the entire team at Remember the Girls. It's been such a pleasure and an honor to work with each of you, and I admire so much the work that you're all doing within your own respective communities. And hope that the tools and resources that I share today can help you along your own journeys. So thank you. I wanted to first start by sharing a little bit more about Expecting Health, because I realize that some of you listening into this may not be as familiar with our organization. So Expecting Health is an organization that's made up of key leaders in health communication. We all have a really strong passion and a background for supporting families where they are. And what do we mean by that? We really mean that we're helping families along their journeys, their healthcare journeys, their pregnancy journeys, their genetic diagnostic journeys. Whatever that journey may be, we're really focused on bringing together experts that can really help and support families along that journey by bridging scientific information with everyday realities. We understand that medical systems, healthcare systems are complex, that newborn screening systems are complex, and we really want to think about understanding what families need to navigate through these complex systems and complex journeys of healthcare and help create and provide support, resources, and tools that really truly meet families where they are. I do want to disclose that the work that I'll share with you today that's part of the Newborn Screening Family Education Program is funded through the Health Resources and Services Administration. We're very grateful for our partnership at HRSA or with HRSA. It's through this partnership that we're able to do this really important work. I also wanted to just lay some foundation for how we think about newborn screening at the Newborn Screening Family Education Program and really share with you what our vision and goals are for this work. Newborn screening is an important public health initiative that happens every single day. And for those of you that may not be as familiar, about 4 million babies are screened every year with newborn screening. And we know that not all families are familiar or aware of what is happening with newborn screening when their infant has that process. And so really our vision for this work and all of the tools and resources that we're putting out there through the Newborn Screening Family Education Program are to help families, to help ensure that all families have equitable access to newborn screening information, and really to have the confidence to participate in that newborn screening system. And so, our goals for the work that we're doing, we are working through a 5-year program, and we're currently in year 3. And really, what we're aiming to do is create a comprehensive newborn screening training program for families that provide them with the information they need to self advocate, know where to go when they need more information, and serve as leaders in the newborn screening system. And we've really had a lot of fun working directly with families to understand what that means in real life. What does it mean to lead within the newborn screening system? What does it mean to advocate for a condition that your child may have been diagnosed with or that you yourself may have? What does it mean to support other families along the journey as they're just getting started and they're just learning about newborn screening? And so through this work, we've been able to develop a number of great resources. And one in particular is our online training module called Navigate Newborn Screening. And I'm going to share a little bit more with you about that today. So again, just to reiterate, all babies born in the United States are getting newborn screening. And the problem or the challenge that this program and the work that we are facing is that many families just don't know about newborn screening. While they may understand or hear that newborn screening is happening, really understanding what happens, when it happens, what to do when results may be out of range, are all things that families are learning more about. And so through the Navigate Newborn Screening online training curriculum, you have the opportunity to take a deeper dive into really what is newborn screening. And for those of you, again, that may not be as familiar, I'm going to give just a very high level background of what newborn screening actually is before I jump into some of the content that you would see in the training, just so that we all are kind of coming from the same page. So newborn screening is a group of screening tests that help identify babies that may be at risk for serious health conditions right at birth. And the reason that that's important and the reason why it's typically done in the first 24 to 48 hours of life is because the conditions that are included on newborn screening all have treatment, care, and management options that are available to help support the best outcomes for that child. So really understanding and identifying babies that are at risk as early as possible help lead to the best outcomes for those babies. When we think about newborn screening, it's typically done in 3 parts. There is a blood sample that is collected through a heel prick, again, within 24 or 48 hours after the baby is born. Babies are often taken to the nursery where this is done, and nurses will just collect a small sample of blood through a heel prick. And that sample typically gets sent off to a state laboratory for analysis and evaluation of a number of different health conditions that are associated with more serious implications if they're not diagnosed early. The second part of newborn screening typically involves an evaluation called pulse oximetry, which is really to measure the level of oxygen in a baby's blood and helps identify if a baby may have a particular heart condition that would put that baby at risk. And the third part of newborn screening consists of a hearing evaluation to determine if a baby may be deaf or hard of hearing. Oftentimes we get asked what conditions are included on a newborn screen, and I'm sure many of you are already very well aware that this can be a challenging question to answer because while every state requires newborn screening, every state is also responsible for deciding what conditions are included on their individual state panel. Now, there is a group of conditions that are recommended. There are 35 core conditions that are recommended on something called the RUSP, or the Recommended Uniform Screening Panel. And this RUSP is typically determined, and the conditions that are on the RUSP are determined by the United States Secretary of Health and Human Services. And through that guidance, each state then has to evaluate, based on infrastructure, costs, and things of that nature, which of those 35 conditions they will add to their panel. And so while every state has newborn screening, there are differences from state to state in terms of the specific conditions that are included on each of those panels. I think the great news is that We've added a lot of conditions to the RESP, or been able to add a lot of conditions to the RESP over the last few years, and specifically few decades, and that list continues to grow. And most states are screening for at least 30 of the 35 core conditions that are recommended. For those that may be interested and do want to learn a bit more, again, we have a lot more information through our online training course called Navigate Newborn Screening, and I'll share with you in just a moment a link of how you can get to that information. There's also additional information available through several websites that I've included here, one of which is called Baby's First Test, and really has a comprehensive overview of a number of different state-specific resources and information about newborn screening, and as well as the Newborn Screening Information Center, which is an additional website that provides, again, introductory information to newborn screening, as well as state-specific information. And again, here is an additional list of some more resources that you may be able to access if you're interested. And specifically, Family Voices, Hanson Voices, and NCHAM are 3 parent-led organizations that really help support families as they navigate through their newborn screening journeys. So specifically with our program at the Newborn Screening Family Education Program, I want to just give a bit of background in terms of what the program aims are. As I mentioned earlier, really the goal and the focus of our work is to support families and to provide education and leadership opportunities for families who want to get more involved in the newborn screening system. We're currently in year 3, and the way that we've really approached this work is in the first 2 years, we spent a significant amount of time engaging with families to understand what family needs are around newborn screening education. What do they really want to know, need to know, and how do families want to learn that information? And the outcome of the needs assessment of over 500 different families led to the development of our online training curriculum, Navigate Newborn Screening. And currently, we are working with partners like Remember the Girls and a number of other groups as well to really help engage and share the opportunity to enroll and take the curriculum or complete the training of Navigate Newborn Screening. And again, as I mentioned earlier, we've really seen a lot of success and a lot of really positive feedback from individuals who have completed this curriculum as a way to build and develop your own leadership and advocacy skills within the newborn screening community. So what exactly is Navigate Newborn Screening, and what exactly is included in it, and why might you want to engage with that training a little bit more? It's really intended to help you learn more about the newborn screening system, to help you connect on a deeper level with other leaders. And I'll share a bit of information about our ambassador program that we've launched in the last year, and how you might want to get involved and connect with other newborn screening leaders. And it's also a way to learn more about specific advocacy skills. So what is included in the online training module? It consists of 5 base courses and 2 optional courses, and we're working to add on a 3rd optional course now. The first 5 base courses are, again, a more in-depth dive into what is newborn screening, how to navigate and understand the newborn screening system and the complexities that make up the newborn screening system. We talk a bit more about newborn screening at the state level and some of those differences from state to state in the disease list, or the panel of conditions that are included. We have some skill development on advocacy and storytelling, and we have a great module with a number of different resources and discussion of resources and tools that are available to help you learn more about the newborn screening system. So if you're someone who is really wanting to learn more and understand what advocacy within the newborn screening system looks like, these base courses will really help you develop some of that knowledge and leadership development. A lot of times we are asked, and so I wanted to just provide some context of how long these modules take and what to expect while you're enrolled in this curriculum. It is free, and so again, we encourage any and all of you that are interested to enroll, and I'll provide a unique enrollment key for the Remember the Girls organization in just a moment. So you can go in, log in for free. It takes about 40 to 45 minutes if you were to sit down and take all 5 courses at the same time. But the great news is that you can take 1 or 2 two here or there whenever is convenient for you, and come back at any time. You can view it from any device, your mobile device, your desktop. You can start and stop at any time. And you can, from a mobile device, do it. You can view the content and information when you are offline as well. So lots of ways to make this accessible for everyone. And we would really value your opinion and your feedback along the way if you do enroll and take this course. And there are opportunities throughout the course to share feedback with us, what you liked, what you learned, and certainly if you have suggestions for improvement as well, we're always open to that. We wanted to share a little bit of what people are saying who have engaged and who have taken the module. So overall, we've really seen this as a successful tool and resource, as I've mentioned before, for helping to develop your own leadership and advocacy skills within the newborn screening system. And so we understand that system is quite complex and that there's a lot to learn to feel confident to speak up and advocate perhaps for the conditions that each of you are working so hard for. And so here's just a snapshot of some feedback that we've heard from individuals who have taken the course. I know several women from the Remember the Girls organization have already enrolled, and we would love to see more of you do that as well. So, lots of comments about the way that the information is presented. It's easy to understand. It's really helpful to understand, to learn more about the newborn screening system, the stakeholders that are included in that, and really how to think about working with them and again, advocating for the conditions that each of you are already advocating for. So I want to leave you, with a few specific things that you can do to get engaged or involved in the program. So first and foremost, we definitely encourage anyone that's interested to register and take the Navigate Newborn Screening online curriculum. There is a specific link provided here, and we'll make sure that each of you have access to that link. This link is specific to Remember the Girls. And so we definitely would love to have anyone interested enroll in and complete this training and share your feedback with us. As I mentioned earlier, there are places along the way where we ask you some questions and seek out your feedback. And we really do take that feedback into consideration as we think about continuing to build on this work, support families, and make any changes that we might need to better serve the families that are using this tool and resource. And the other opportunity I want to share with you is that we do have an ambassador program that we've recently launched. We're always looking for other individuals who are interested in joining that ambassador network. And so for anyone who completes the Navigate newborn screening online curriculum, if you're interested in staying engaged with our work, working with other families, learning more about the newborn screening system and advocacy within that screening system, we do have an opportunity to join our ambassador network. And we are looking to start hosting quarterly events for that network as a way to meet other family leaders within the newborn screening system, as a way to continue learning and developing your leadership skills, and really as an open forum. And we are leaning on that ambassador network to also reach out and help share the opportunity for Navigate Newborn Screening with other families who may benefit from this training. And so we would certainly welcome anyone that's interested to join us. And if you are interested, please feel free to reach out to me, which leads me to again, just to wrap up, I really do thank you for the opportunity to share more with you. This is really exciting and really important work, and I feel honored to be able to be a part of it. And I certainly hope that if any of this is resonating with those of you that are listening in, please don't hesitate to reach out to me. I would love to connect with you. I would love to talk more about how we can best support you in your journey. And certainly if you're interested in getting involved, again, we welcome and encourage that. And thank you so much, and hope to hear from many of you soon.
That was a great video, going over some of the basics of newborn screening in the US in particular, but also the Expecting Health Navigate Newborn Screening course. I took it a couple months ago, and I thought it was really helpful, especially for those who want to get started in newborn screening advocacy, but don't really know where to start. So I posted the link to our specific program link, so you can sign up on behalf of Remember the Girls and take the course. And I will also post this in the Facebook group as well, but I definitely do recommend it. All right, now moving on to our second leg of the webinar today. I'd like to reintroduce Abby Watts-Dickens, who is here today. She is a genetic counselor from Canada, who has a lot of experience working in newborn screening. And she's just going to share more about newborn screening as a whole. Also from the Canadian perspective, we do have members that are in Canada and are in many other countries besides the US. And she will also be talking about the implications of identifying X-linked carriers through newborn screening. So if you have any questions for her, please send them in the chat or in the Q&A, and we will get to them at the very end. All right, Abby, you should be able to screen share. So take it away.
Thank you, Taylor, for that introduction and for that intro video as well. That was very a really nice kind of segue, and I think that addresses a bit more of the process and some of the steps for our viewers on how do I get started next and where do I go for more info. So I think that's really complementary to this talk as well. And again, thank you, Taylor, and to the Remember the Girls organization as a whole for inviting me to speak. I'm really looking forward to getting into some of this and talking a bit about my work and sharing some of my expertise with you. And I'm also looking forward to a spirited discussion at the end as well, because discussions on carrier testing and ethics always spur lots of discussion, which is part of why I like what I do. So again, my name is Abby. The pronouns that I use are she and her. And I am a genetic counselor in the newborn screening program at SickKids Hospital in Toronto. SickKids is a major pediatric teaching hospital, and the primary responsibility of my role is the follow-up of infants who screen positive on the Ontario newborn screen, which includes metabolic, hematological, endocrine, respiratory, immunological, and neuromuscular conditions. I'm also a genetic counselor at a clinic called MedCan, which is a private health clinic. I'm a lecturer in the Department of Molecular Genetics at U of T, and I have no conflicts of interest to declare. Before I get started, I would also like to begin by acknowledging the land on which I live and am giving this presentation. For thousands of years, this land has been the traditional land of the Huron-Wendat and Petun First Nations, the Seneca, and most recently the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island, and Turtle Island is the name that many Indigenous peoples use to refer to the continent of North America. What I plan to talk about today is, trying to progress to my next slide. Here we go. Some of the principles of population-based screening, some history on newborn screening, which I think can be really helpful when we talk about expanded newborn screening. Where do we go from here? Understanding where we have come from in newborn screening really gives some context for some of the challenges and considerations that need to be taken into account. Talk about current newborn screening practice, future directions of newborn screening, identification of carriers through newborn screening, and some questions or things to think about as we expand newborn screening and how do we proceed. And then of course, a discussion at the end. So this image here is, I just wanted to give a bit of theory about newborn screening and population-based screening in general. The goal of newborn screening, or of even if you take it back a step further, of population-based screening, is to screen ideally everyone in the population, so low risk or population risk individuals, and identify a subgroup that is at increased risk of whatever target condition you are trying to identify. So this is an example from Perinatal Services BC, which it's describing more prenatal screening for Down syndrome, but the theory is the same. So if we have an entire population of women who are pregnant, and we test all of them using some sort of screening method, the dark gray women here represent those that are screen positive. That does not mean that the fetus will certainly have Down syndrome, but it means that they are at increased risk. And this is the target population that we've identified that now we can do a more specific or diagnostic test in to determine with greater certainty whether or not the fetus has Down syndrome. So within this group, a subset of those women will have a fetus who is affected with Down syndrome, but the majority of them don't. And so the dark green here are what we would call true positives, and the darker gray would be false positives. The light gray would be true negative, women who screened negative and the fetus does not have Down syndrome. And in any screening program, there is the risk for false negatives, which would be a woman who has a negative screen, but the fetus in fact does have Down syndrome. So this would apply for newborn screening as well. If we have a screen positive infant or screen negative infant, this terminology and theory all remains the same. The primary goal of newborn screening is the early identification of affected infants to prevent serious health problems before they occur. And I think that's really some of the key words here is prevention, and to identify and initiate treatment and prevent symptoms or significant impacts in the child. The origins of newborn screening started in the 60s, and I think you can't really talk about newborn screening without talking about PKU, although it is not X-linked. I still wanted to talk about it. So Robert Guthrie identified a way to screen infants for PKU. I'll talk a bit more about that in the next slide, but it has evolved into a highly successful public screening program. And I think newborn screening is really widely regarded as how to do screening well in a population. So this is technical, but I will give my kind of genetic counseling lay term explanation here for PKU. So PKU has to do with how we break down a certain amino acid in our body. So when babies are taking breast milk, formula, or solid food, whatever we're getting our food from, protein is a major component of that. Protein is made up of amino acids. One amino acid is something called phenylalanine. And this enzyme, phenylalanine hydroxylase, converts phenylalanine into tyrosine. If someone has PKU, then phenylalanine hydroxylase is not able to work properly, and that individual is not able to convert phenylalanine into tyrosine. As a result, we have very high concentrations of phenylalanine because it builds up. We're not breaking it down. And then we would also get a deficiency of tyrosine. At high levels, phenylalanine is neurotoxic. And if it builds up in the blood and in the central nervous system, then that can cause significant impacts on a child's development and seizures and other concerns. But this condition is treatable, because if we know that someone has PKU, at birth or as early as possible, we could start them on a medical formula that is free or very low in phenylalanine. And if we eliminate the problematic component of the diet, then these children do very, very well. And if there is strict adherence to the treatment, often reach their full neurodevelopmental potential, and it no longer becomes life-limiting. So it's really kind of this classic example of a newborn screening condition, where if you can identify before a child has problems that they do have PKU, then we can prevent these developmental impacts from happening. And so Robert Guthrie identified the Guthrie test and these Guthrie cards, where you can prick the heel of the baby, put blood on a filter paper, and then it can be stable at room temperature. They can store it and test it later, and then measure the concentration of phenylalanine in the blood. So this was a way to universally screen all infants at birth, and the blood spot card really changed things, because this was a way where no matter where you're born, no matter what type of facilities you have access to, a midwife or nurse could prick the heel, collect this sample, and then babies could have equal access to this screening. And then equal access, as I'll go on about, is really important in newborn screening. So newborn screening now looks for many disorders, but these were kind of where it started. Newborn screening has expanded beyond the blood test, and that was touched on in our previous presentation. There's now universal hearing screening, pulse oximetry screens for critical congenital heart anomalies, heart defects. And there are other ways. It's expanding beyond the blood spot, but the majority of conditions are screened with this blood spot. Again, it would feel wrong to do a chat on newborn screening and not talk about Wilson and Younger. They published many decades ago some screening criteria, not specific for newborn screening, but for population-based screening. But years later, this is still really kind of considered the gold standard in terms of what do you screen for and what is an appropriate screening test. And so they created these 10 criteria for population-based screening. And there have been modernized interpretations of this as we move into more genetics and genetic-based testing, but a lot of them still really boil down to these 10 kind of classic criteria. So the condition should be an important health problem. And I'll go through this using PKU as an example because it's kind of the classic newborn screening condition. So I think that untreated PKU is an important health problem. And I think that's kind of universally agreed upon. There should be an accepted treatment for patients with the condition. And so I think it would feel unfair to screen infants for a condition where there's nothing that we would do differently for them. What would be the purpose of identifying the infant if there's nothing that could be done to help that child? Facilities for diagnosis and treatment should be available. So again, what's the point in screening for something if we can't follow up on that and then actually initiate treatment and provide care for the child? There should be a recognizable latent or early symptomatic stage. So if you knew immediately at birth that the child had the condition, then we wouldn't need to do the screening test because then we would already know that they had it. Then if an examination or a pediatric exam at birth could find it, then we wouldn't need to screen for it. There should be a suitable test. So there needs to be a reliable test to identify the condition. And the test should be acceptable to the population. So it should be the target population, families with PKU, the general public should want this test. We shouldn't be imposing it on a group that doesn't want it. There should be a good understanding of the natural history of the condition. And there should be an agreed policy on whom to treat. So we should know who's eligible for treatment, who out of these babies that we identify, who do we treat, who do we not treat, should be cost effective as a whole. And that there's kind of the cost benefit as well that should be considered. And then the last one, that case finding should be a continuing process and not once for all. So there should be constant review of, is this a suitable screen? Is this screen performing as it should? Are we truly identifying and helping these kids as we sought out to do? In Ontario, we have actually removed a condition from the newborn screen because after it was implemented in a number of years, upon review, it was realized that it wasn't really as effective as we had originally thought, and we were identifying a lot of healthy babies. And so it was actually re-reviewed and taken off of the newborn screen. So I'll touch on the disease nomination process in the United States. And I'm sure that if you do the course that was aforementioned, that you'll probably learn a lot about this. But ultimately, it starts with public nomination. So members of the public, advocacy groups that will go and can nominate a condition to be considered for newborn screening. And there's a lot of information online, and I'm sure in the modules, in the training modules as well that we just talked about, to learn about how to do that. And with a quick Google, there's a lot of info that you can find on there and forms as well. So you would nominate a condition, which would then be reviewed by the Advisory Committee on Heritable Disorders in Newborns and Children. And after a review process, they would make a recommendation to the Secretary of the Department of Health and Human Services as to what to include on the recommended uniform screening panel. So this is a group of conditions that is recommended for consideration in state newborn screening programs. But then it's up to each individual state as to what they include on their newborn screening program, how they screen for it, what their follow-up looks like. And then, so each state would consider the RUSP and then have their own state-specific newborn screening panel. The states are not bound by the RUSP. You can screen for disorders that are not on the RUSP. And just because it's on the RUSP doesn't mean that you have to screen for it, but it's guidance. In Ontario, this is a nice infographic on our newborn screening program, and I apologize, the resolution isn't fabulous, but it's still legible. I'm not going to go through this in detail because I could spend 20 minutes on this slide, but I think this gives us a nice overview of, aside from, like, after you decide that a condition will be on the newborn screen, what actually goes into the screening process as a whole, and a lot of the different moving parts that I certainly didn't appreciate until I started working in newborn screening. So this pink circle here is our newborn screening lab, Newborn Screening Ontario, and it's based at the Children's Hospital of Eastern Ontario. So it's a centralized lab that does testing for all of the babies in our province. So they do the testing, the quality assurance, and education as well around this. There's a lot of data management that goes into that. And before this, we need to collect newborn screens. So birthing hospitals, labor and delivery units, midwifery centers, even if it's at home, if there's a home birth, the midwife would then collect a newborn screen and ship these blood spot cards at room temp to the lab who does this testing. If there is a abnormal result in Ontario, then that child would be referred to a follow-up treatment center who would then contact the family, initiate a diagnostic process to confirm or rule out the condition, because a positive screen does not mean a diagnosis, and then also manage treatment and initiate treatment for babies who are confirmed. So this is where I am. This is where I fall into this. And so this is how I fall into this whole piece. We also have an advisory council, which determine which diseases are screened for on the Ontario newborn screen. So if the advisory council, through public nomination as well, decides that they would like to have something on the newborn screen, they go to the Ministry of Health, who would then hopefully agree to fund that test. And the submitters, I talked on this as well. Something that I want to touch on in future is consent, and something that's really important to think about in newborn screening is that as of current, the model is presumed consent. So there is usually not an explicit conversation at the bedside prior to discharge from the birthing hospital where the nurse doesn't sit down and say, this is newborn screening, this is what you'll learn, this is what you won't learn, do you want this test done? They come in, they collect the blood, it's routine. If you want more information, there is info available in Ontario. There's a little tear-off sheet from the blood spot card that's given to the families with info on how to get more information on newborn screening. But really, it's just automatically done unless someone basically stops the nurse and says, whoa, 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 what are you doing? What's this blood test? Usually there's not much of a conversation. And this works because all of these conditions are very thoughtfully considered for newborn screening. And it's agreed that it's in the child's best interest to be screened for this condition, and that explicit informed consent, we can get around that by being really thoughtful in terms of what goes on the newborn screen in the first place. So I already touched on this a bit, what I call old school newborn screening, PKU, and a lot of those conditions where it's a dry blood spot. And we're looking for some sort of biomarker that allows us to identify which infants are at increased risk. So for PKU, that was measuring the concentration of the phenylalanine amino acid in the blood. For hypothyroidism, another classic newborn screening condition, a high TSH in the blood spot would allow the baby to be flagged. In CF, we measure the concentration of an enzyme called immunoreactive trypsinogen. So blood spot for some sort of biomarker. And the difficulty in that is that you're really restricted by, is there a good biomarker? There's a lot of conditions that we would love to screen for that do have good treatment, but we don't have a good test for them. And so that wouldn't satisfy that Wilson and Younger criteria, where we need to have a reliable test that allows us to identify the at-risk infants. Now we're moving more towards DNA-based testing. And this gets us through a lot of those barriers of needing a suitable biomarker. Most conditions all except for one, conditions on the newborn screen are genetic. So theoretically, if you have a gene and you know that there's a causative gene for this condition, if you can sequence the gene or do a genetic test, then you're able to detect that condition. So we're getting past a lot of those barriers from traditional newborn screening methods. Now that we have an increased use of DNA-based technologies, there's a huge potential to broaden the scope of newborn screening because, as I mentioned, we're no longer restricted. I imagine that by the time I'm finishing my career, we may be doing whole genome testing, sequencing all of the known genes at birth. Maybe we won't be disclosing all of that information immediately, but it's not unreasonable to think that we're moving towards a system where there's a lot more genetic testing done at birth in babies. As I mentioned, there's other methods as well for doing newborn screening for other conditions in different ways, but the majority and the mainstay is the blood-based testing. Now that we are having these technological advances and genetic testing is going down in cost and increasing in access, as we're no longer restricted by these biomarkers, the question is not, can we test for this condition? It's should we be testing for this condition? And there's a lot of careful thought and deliberation that needs to go into whether or not to add a condition to the newborn screen. And now we're more kind of driving based off of, is there an available treatment? So if there is an effective treatment that's being developed for a rare disease, once that treatment is approved and is being funded by insurers or by the Ministry of Health in Ontario, then that is more likely to be the driving factor now because the technology exists to screen for it. Some of the complicating factors, though, as we start to test for more conditions, are that how do we manage conditions that have mild variants, where if a child has a classic or severe form of the condition, then that would absolutely satisfy our Wilson and Younger criteria, and it absolutely makes sense to screen for. But what if that's only 10% of babies with the condition and the other 90% have a mild variant that don't qualify for treatment or that may have adult onset disease? And so the lines are starting to blur in terms of these classic newborn screening conditions. We're starting to potentially detect milder variants and later onset conditions. And there's other ethics that go along with that. As we do DNA-based technologies, how do we manage disclosing carrier status? And I'll talk more about that. And how do we manage uncertain genetic results? So every time we do genetic testing, there's a possibility that we could find a variant of uncertain significance, which is a variation in a gene where we're not certain whether or not it actually causes the condition or is associated with risk for the condition. So what do we do if we identify a baby who has a positive screen based off of an uncertain genetic result? And if that genetic variant does cause disease, then they would have the condition. But if it doesn't, then they don't. And that's a lot of uncertainty to have in a 2-week-old infant. When we are thinking about adding a condition to the newborn screen, we need to think about what is the overall net benefit of screening and what's the feasibility. So even if we can test for it, are there enough specialty centers in the state that can offer this follow-up? Are there enough specialists well-versed in this condition to provide adequate care for these families? Are there facilities to provide the treatment that we need? Are they located in places where it's reasonable? What's the geographic distribution of these centers in that state? Is it reasonable for these families to access that by car? This wouldn't be helpful if the families can't access the facilities for treatment. What are the overall system-wide costs for the follow-up? And what are the potential harms for identifying this condition? Overall harms and benefits of newborn screening. I think the benefits are very clear. Early diagnosis and treatment, improved outcomes for children where early intervention is essential, avoiding that diagnostic odyssey of going through multiple referrals for specialists and taking months or years to arrive at a diagnosis when we could have been treating it from birth. Family planning for future children. Most parents, if they're having kids, then they're in their active reproductive years and they are likely to have other children, and maybe they'll actually have other pregnancies before their affected child even reaches a diagnosis. So newborn screening is an opportunity to help families as a whole and not just the child. Empowerment for families. And not missing any cases if we have a rare disease where family physicians or general pediatricians just might not be as familiar and able to diagnose. And I put identification of carriers as both a benefit and a cost because it can be seen both ways. Anxiety of false positives and of families going through the newborn screening odyssey. I see that firsthand every week with our families. This is very, very stressful. And for the majority of families, there's literature to show that it's acute stress and then they go back to kind of normal stress levels after. But there could be families that have residual anxiety and residual psychosocial concerns from going through that newborn screening process. Could we possibly be interrupting bonding during a really critical time for moms and dads or for parents and their babies? Could we be initiating treatment unnecessarily in children with mild variants that may not need treatment? Are we over medicalizing kids who have mild versions of these conditions where they've been identified just because we screened for them, but they may have gone their whole lives otherwise without a diagnosis and they would have been fine? When we think about some children who might have mild variations of a condition, they're not eligible for gene therapy or stem cell therapy or any of these novel conditions. And then we're just kind of waiting to see if they develop symptoms and then initiating treatment. And I think that the amount of anxiety for some families there should not be undermined. Cost of implementing and following up on new conditions, and then identification of carriers. Some things to think about. I'm going to skip through here. Carriers. Okay. I wanted to briefly touch on recessive conditions because when we have a carrier of a recessive condition, the vast majority of time, they are not at risk for symptoms, full stop. So it's much easier for newborn screening programs to just not disclose carrier results for recessive conditions because that child is arguably not at risk. There are always exceptions to the rule, but generally speaking, that's how it goes. I know I'm preaching to the choir here, but obviously we have a different story with X-linked conditions. A mom who is a carrier, she could show symptoms. Oftentimes, female carriers of X-linked conditions may have a really distinct female presentation, but depending on the X inactivation, and there are always exceptions to the rule, there can be some children who have what is more in fitting with an affected male child. And so the range of severity for female carriers is specific to the condition in question, but generally very wide ranging, often more adult onset, but there could be women with younger onset as well, which really muddies the water and makes things really difficult. So what if we do newborn screening for an X-linked condition and we decide to disclose carrier status for women? this can be beneficial because it allows the earliest possible identification of young women who will show symptoms of the disease, as opposed to having them go through the diagnostic odyssey. And that would allow for the earliest possible intervention as well. It would identify at-risk family members and allow for family planning. As I mentioned, parents are often in their reproductive years. It might not be their last child. They could have more. Family planning for the child's siblings. And this would be an opportunity to identify all carriers on an equal access basis, because it's universal and everyone is being screened regardless of their insurance status or where they're born, which would get through some of the other barriers. And if we know that a young girl is a carrier, then parents have the opportunity to slowly introduce them to that concept throughout their lives in age-appropriate ways, at age-appropriate intervals, and allow them to kind of slowly integrate this into their lives, so that by the time they're thinking about having children, they have a better sense of where to go, as opposed to early in pregnancy, and then you're making a rush decision on how do you proceed. Some of the difficulties: parental anxiety, anxiety for the child, knowing that they're at risk. I think that's could be very significant for some and less significant for others, and we won't know what's what until we identify those women. Over-medicalization of healthy kids. And I think it's very possible that the child may be mislabeled as affected. And if that gets into their chart, it's kind of difficult to get that out of the chart. Could there be stigma and discrimination for them? Would they possibly not be eligible for extended insurance? What would insurance look like for them in a person who is otherwise going to be generally quite healthy? Cost to the medical system for follow-up and monitoring of carriers. And I think a big one that comes up is loss of autonomy for the child. There are a lot of people who would choose to not know this information. And if we're automatically disclosing that at birth, then we're taking that away from them. And it's really, I think, overall, what is a bit of a mindset shift for people is that it's really a change to the traditional dogma of newborn screening. Because for many X-linked disorders, what we would essentially be doing at this point is screening for an adult onset disease. And that's not the mainstay of current newborn screening. So that's a really big shift for people there. And something to think about as well, like this is an opportunity to identify carrier females, but is that really the goal of newborn screening? Is that really what we're trying to do here? Could we offer, universal carrier screening in adults as a possible other option? I know we're short on time here. Consent, really quickly. So I think it would not be reasonable to just say, well, we're not going to go there. I think we are going there, and we're going to need to find solutions on how can we implement this well and thoughtfully and safely to protect and help women who are carriers of X-linked disease, but also protect the other side as well. So thinking about our current consenting model of presumed consent, one way that we could proceed if we're doing genetic testing or newborn screening for X-linked conditions at birth would be to keep the current consent model and just not disclose female carrier status at all. The data is withheld, you cannot request it. Probably not the best option, but that is one option. We could keep the current presumed consent model and just test boys only, or test babies who are assigned male at birth only. That's where some European countries are going. I think that's really paternalistic, but that's the direction that some are choosing to go in. Something is a positive disclosure model, and that's what we're doing for sickle cell screening in Ontario, where the data is available. It's not reported, but if you want it, then you can request that information. So parents or family doctors can request that information from the newborn screening lab at parents' request. So it's not automatically disclosed, but it is available and you can request it if you like. Maybe we just do explicit informed consent for all newborn screening. I don't know. I think that would be difficult to implement because there would be a lot of resources needed to have that conversation after birth. We could do a tiered consent where, let's say, there's the automatic newborn screening panel where there's the current newborn screen, and then males are automatically tested for the X-linked conditions at birth. And then if parents want their female child tested, then they have an informed consent conversation so that they can decide whether or not they want to learn this about their child. I think on paper that sounds like the best option, but of course we would really need to change how newborn screening consenting is done. We need a lot of resources to support that. Other considerations, I will breeze through this really quickly, but I think that ultimately we need to, if we're going to be disclosing carrier status, there needs to be some sort of medical benefit for the child or young adult for learning that information. And ultimately, I know this is a bit of a plug for genetic counseling, but competent genetic counseling in public education is really essential. And I think that newborn screening carrier disclosure, it's not going away. It's something that will be coming. So we just really need to make sure that it's implemented responsibly. A summary as well. I basically just went through that, so I'll skip this. And this is me and my team, my small little team. Myself, I'm a genetic counselor, and Megan Fraser is a registered nurse that sees the newborn screening babies with me. Thanks for your patience. I'm sorry I went 7 minutes over, but if we have time, I would be happy to chat.
Yeah, thank you. Thank you so much, Abby. This was an amazing overview. And, I loved how you went both into the history of newborn screening, where it is today, and how there are so many considerations that, we're having to face, especially as we are screening for more conditions, especially X-linked conditions. It would also be, I'll email about you this after, but for those who maybe would want to look at some slides of the presentation, like more in depth, or especially about the carriers, I think that would be awesome for our group. But we do have 2 questions. So the first, and you did touch on this a little bit, but should expanded carrier screening grow in addition to newborn screening?
So I hope I would maybe want to clarify that. So expanded carrier screening in adults?
They didn't say, but I'm assuming I think now it's mostly done like in adults pre-pregnancy. So I'm assuming just that, but
yeah.
More.
So I think that is one of the, yes, I do think it should. That's the short answer. The long answer is that I think that's a great solution as well to get around some of the ethical concerns around disclosing carrier status on newborn screening, because one of the biggest arguments for disclosing carrier status on newborn screening is the reproductive benefit. And so if we could more universally offer and adapt expanded carrier screening for these conditions, then that would get us past the reproductive benefit argument, and then maybe still protect those women that would choose not to know that information. So yes, I think it should be more widely offered, and Canada is way behind on that. Like, we're not even doing universal CF screening. So we have a lot of work to do in that department. And I absolutely think that it should be expanded, provided that there is adequate pre-test counseling. Because I think that there should still really be that conversation with the woman and her partner, depending on what her status is, on, do we really want to know this? Because once you know that you're a carrier of a condition, you can't unknow it, and being really thoughtful in terms of, do you want that information or not?
Definitely. Thank you. So our other question is, where X-linked conditions such as adrenoleukodystrophy are picked up in female newborns who are carriers, what is the appropriate follow-up to make sure that these females are eventually made aware of their carrier status? Is it solely up to the parents? And I think this is also in the US, as you know, they do disclose the carrier information to the parents for ALD. They don't, in some of the European countries, but I think this is coming from a US perspective.
Mm-hmm. So currently it's disclosed to so I'm going to speak to my best knowledge because I am in Canada. So don't take what I'm saying as complete gospel, but what my understanding is from reading the literature is that really parents are considered the best proxy for the child. And so all of this is disclosed to the parents. And I think of when I identify CF carriers through newborn screening, I'm providing genetic counseling to the parents, although technically the baby is my patient. But of course, if I have a newborn, I'm not counseling the newborn, I'm counseling the parents. And so what we do is make sure that they have adequate genetic counseling and that they are equipped with the education and the tools on how do I share this with my child. And often my approach is spending as much time as the parents need to ensure that they understand the information. And also, kind of doing some coaching with them on how do I bring it up? How might I bring it up? The bottom line that I always say to my families is that giving this information as it naturally comes up, because I think these conversations, if you look for them, they do, kids ask questions a lot, and being able to answer all of those questions honestly and at an age appropriate level. That being said, I do think that having some standard genetic counseling in adolescence would be really, really beneficial. And I would love to see that built in. If it's not built in, for when the girl is 14, 15, not that she's likely not actively family planning at that time, but as you're starting to think about, what your future looks like, those are natural thoughts that we have, and being able to then provide that direct education to the adolescent is also really, really helpful. So what I usually say to families is, share this with your child. However, when they're older, it's important that they get a referral for their own genetic counseling.
That's great advice. Thank you so much, Abby, and thank you to all of our attendees who came to watch this. As I mentioned, this will be recorded and posted on YouTube and our website at a later date, so you will be able to view it then. But yeah, thanks everyone for coming out on a Saturday. Abby, this was an amazing overview, and I'm so glad that our group has this resource to look to. And I just want to thank you for all the work that you do in your profession as well. All right, everyone. Thank you and have a good rest of your weekend.
Thank you so much, Taylor.
Thanks, Abby. See you later. Bye.